Hello, I'm Dr. Steven Sparagona, and I work very closely with pediatric patients who have TSC. Now, I'd like to share my experience with you. If there aren't any significant neurological issues, I may see a patient every 1 or 2 years. If there are significant neurological issues, such as epilepsy, that's well controlled, I'm typically seeing them twice a year. But if patients are having difficulty, I may see them every 4 to 6 weeks to address changes in their medications and the status of their seizures. In the U.S., the recommendation is to image every 1 to 3 years looking for a potential SEN or SEGA growth. There may be circumstances in which I would increase the frequency of imaging. So if I saw that a SEGA was starting to grow, I may advance monitoring to every 3 or 6 months to determine whether there's a significant growth rate. Regarding epilepsy, if it's controlled, I may do an EEG at baseline. If they are candidates to come off treatment after 2 years of being seizure-free, I typically recommend another EEG at that point. However, if the patient is not controlled, I may recommend more frequent EEGs, and they may go into an epilepsy monitoring unit for seizure characterization. This process helps to characterize the seizure type, localizes the area where the seizure begins, and may serve as a pre-evaluation for epilepsy surgery. As a child neurologist, I followed kids up until the age of 18, and then I transferred care. I do have a sense, though, that many adult neurologists are not in tune with the TSC imaging protocol or the approach to imaging. They're often not aware of the brain lesions, their potential for growth, and so on. A similar situation may hold true for renal disease associated with TSC, which is more likely to cause problems in adulthood. I mean, it can cause problems in children and adolescents, but it's more likely to become a complication in adults. So monitoring may be especially useful. I'm not certain that this monitoring is accomplished in the adult patient population as well as it is in children. Neurologists concentrating on the adult population may not have the specialized knowledge and expertise with this disease. In my view, an adult neurologist is most likely to see neurological concerns in relation to their patient's epilepsy. I would advise that neurologists truly understand their patient's epilepsy and know what their brains show in terms of tumor burden. Also, if there is a lesion near the foramen of Monro, they may consider monitoring with MRI, at least to know what their brain looks like at baseline. They should also be knowledgeable with regard to other non-neurological manifestations of the disease, for example, the potential for kidney disease and lung disease.